I'd like to begin by thanking you all for your efforts on the effort trial. Maybe you're getting sick of me saying it in that way. But this is really an example of almost a global community coming together to answer a very fundamentally important research question, and it relies on that spirit of volunteerism that each of you are manifesting. So thank you for that, and thank you for your willingness to join us today. Our goals today are sort of to review what we consider to be best practices, or at least to share experiences of what you're having on the front lines as you screen and enroll patients. I want to acknowledge our colleagues at the University of Pennsylvania, Charlene Comfer, Mariana Lupus, and Jennifer Dolan, who were our first site out of the gates and met that goal of reaching 30 patients. And our other colleagues from Legacy Salmon Creek Medical Center in Vancouver, Washington, Raquel Regala, Jerry Howick, and Joseph Jura, who were second to that mark of achieving 30 patients. We thought that having them present would help us in this conversation as we discuss the effort trial and, on the front lines, how is it going?
Wow.
Maybe before we jump in there to that discussion, I'd just like to update you globally with the status of the trial. We have over 100 sites that are interested in participating, 39 of which have been activated across 9 different countries and different regions of the world. And the map shows you, where those different sites are, those that have been activated, those that are in the queue. To date, we have, I think it's close to 285 or something patients randomized from those 39 centers in 9 countries. So the ball is rolling forward and gaining momentum. We have a bunch of sites in the UK that are set to join in the next upcoming months. And well, as you can see on the slide, there's sites in various parts of the world that are just about to come on board. We felt like, this discussion about how to optimize recruitment, how to be more efficient at screening, how to increase the amount of protein provided to the high dose group so that we see a better separation of the 2 groups would be super important to the execution of the trial, and then to minimize some of your distress and angst and workload, just some discussion about data capture and query resolution. So that's really our agenda today. It's pretty loose, it's pretty informal. We're gonna hope to have some discussion and question and answers. I thought I would start by inviting our UPenn colleagues. Jennifer, I don't know if you're the only one still on the line, if you're the voice, or if between you and Marianne you wanted to share, what your experience was with respect to screening, and particularly any tips or tricks that you developed to make it more time efficient for yourselves. Following your thoughts, I'll ask Raquel to also reflect the Legacy Salmon Creek experience, and then anybody else that wants to share any tips or tricks or things that have made their life easier as they screen for effort. And then we'll just pause on this subject and have some discussion and questions and answers. Jen, did you want to lead off then?
So one of the first things we did that was very helpful was we met with all of the critical care pulmonologists, because they are all doing research in the health system. So once a month they have a research meeting, and we got invited to their meeting with the specific people who are doing research, and made sure that we had buy-in from them. And Charlene did a formal presentation to that group and question and answer period, so that everyone was able to hear what the protocol was and make sure that they were truly committed before we started enrollment. Not every pulmonologist who works in our unit does research. At Penn, you can do a research or a teaching track. So the pulmonologist who chose the teaching track can be on service when you're enrolling subjects, and they have not been given the formal presentation. So one thing that we would recommend to people that are enrolling now is to make sure that you have 100% buy-in, that if the subject is failing to meet the 2.2 gram protein requirement, that they are willing to put their patient on supplemental parenteral nutrition, because that's one thing we found difficulty with if a patient was failing enteral feeding, to get that full distinction between the two groups. The other thing that we noticed is during the screening process, it was challenging to know if the subject was truly going to be in the ICU on nutrition support for an extended period of time. So a lot of discussion took place between us as the people enrolling and the pulmonologist, in trying to get a good estimate of who would actually be a good subject for the study, because people we thought would be intubated for more than 72 hours ended up being extubated, and people who we thought would be extubated really quickly ended up intubated for a long time. So we had inappropriate people enrolled and missed opportunities for other better subjects. So I think the dietitians should trust themselves in their assessment of who's going to end up on nutrition support for an extended period of time. I think that the pulmonary team often just either A, defers to us, or B, says, sure, go ahead, enroll them. They'll be here. They'll definitely be here for 72 hours, and then they're extubated. So I would say, trust that you've been a practitioner for a long time, and you know who's going to end up on nutrition support. Those are the main things on my end of the enrollment side. And then Marianne did a lot of the actual data collection.
I just assumed it would. I didn't even try. I'm sorry.
Yeah, so I would say from a day-to-day standpoint, when we decided that we were going to start screening, we kind of picked a point in time and started looking at all of our ICU patients. Our unit has a really high acuity level, and so we get many transfers in from other institutions. And so being able to identify the patients who had had a long ICU story before they came to our institution was definitely something that we looked at to optimize our efficiency, because we didn't want to waste time on a patient that had been ventilated for a really long time prior to their transition to our institution. On a day-to-day basis, we would screen the ICU list, find out how many patients were new, look at their ICU length of stay, and then we would kind of share the list. Jen and I would talk on a daily basis, and then she would introduce those patients to the ICU team to get their assessment of whether or not they thought the patient would be sticking around and staying in the ICU for a long period of time. We learned that I think that's a little bit more of an art than a science, and it really takes collaborative discussion to get to the appropriate patients, because initially we enrolled patients that may not have met criteria and were not quite as sick. And at the same time, we missed a couple of patients who were very sick and could have been enrolled. So really having those conversations from the get-go was a really valuable part of learning how to screen effectively.
So Marianne and Jen, this is Charlene. Because we were the first site up, I think that we may have been influenced a little bit by prior participation in the INS. And we tried to enroll a lot of patients as quickly as we could. And was that also a challenge, just enrolling too many too fast?
Yes, I think we were really enthusiastic, and we thought, oh, sure, we've got some nursing students who will support us with our data collection and the day-to-day care. And so we enrolled very quickly, got a lot of really high acuity patients. I mean, we enrolled 30 patients over 6 or 8 months, and of the 30 patients that we enrolled, I think we screened over 100 patients. So we had a lot of patients that we evaluated that we did not enroll. But I do agree, Charlene. I think that in hindsight, we should have stopped ourselves and said, okay, we've got 2 or 3 good candidates. Let's watch them closely and then transition on to a couple more once we're finished with those patients. Because when you have many balls in the air and you've got recently screened patients and patients actively enrolled, and you're trying to follow up with the teams about enrolling new patients as well as meeting target goals for protein, in the midst of a busy clinical practice, it gets difficult to make sure all of those things are happening at the same time.
Jen, you mentioned that we did a presentation to the MICU team, and that seemed to be very effective at bringing them on board. Do you think that there is an advantage for doing that repeatedly whenever, maybe when the staff turns over or people go on other rotations?
So, because I think most of the people have chosen their track. Like, we have a lot of senior people who have been here for a long time. So you may get 1 or 2 new fellows that stay, but the time, I don't think that you're going to get that much of a difference.
Okay.
Yeah.
But I do think from a screening standpoint that it might be worthwhile every time you are ready to enroll, Jen, as you mentioned, to make sure that you are saying very clearly to the provider that if the patient can't meet their enteral goal, we need to start supplemental parenteral. And that's probably a worthy conversation to have with every single enrolled patient.
I agree.
Yeah, can I just jump in there, because what we see, and we'll talk more about this when we talk about, you know, maximizing the difference between the 2 groups in terms of the protein intake, is that people are not really utilizing enteral protein supplements. And so I would stress that that be the first tool out of your toolkit to maximize differences before you jump to supplemental parenteral nutrition. I'm not saying don't use supplemental parenteral nutrition when you're maximizing the enteral approach, but from the data that we've been collecting on enrolled patients, under utilization of enteral protein supplements on top of your enteral nutrition is the lowest hanging fruit to reach for. Now, that might not be specific to UPenn. It's just globally speaking, you know, using more enteral protein supplements would be the first tool that I would advocate for before jumping to supplemental parenteral nutrition.
That's a great point, Darren. And I think we're biased at our institution because we tend to use a lot of protein. I think anecdotally, we tend to be really big believers in protein. So we've always given large quantities of supplemental protein. And so we just kind of forget that that's not something that's happening globally.
Okay, good.
And you also were using a lot of enteral protein supplements, but you're talking about patients for whom that was not feasible for some reason, correct?
They were just not tolerating enteral feeding for one reason or another. The patients that we enrolled, their acuity was very high, and many of them just had a lot of GI intolerance to enteral feeding and just weren't able to be sustained on enteral feeds alone, despite many aggressive measures.
One other thing I would just throw in, it's not specific to screening, but indirectly, we probably had 1 or 2 subjects that we ended up having to change the goal midway because they weren't tolerating the super high protein intake. And we have a large liver failure population and liver transplant population. So patients were developing encephalopathy. I think we had 1 or 2 patients drop out from that. And we did not exclude a lot of patients. You have that option to exclude if you don't think you have equipoise, then you have the option to not include that subject. But one of my things is all of our patients are so sick, and I would like when the results come out to say, okay, well, this is the protein recommendation, but it only applies to like 10% of our ICU population. That's not really valuable. So I kept a lot of different patients in, and had to stop the high protein in one or two of them. So that's something else to just think about, who you're enrolling and who you're saying, I don't believe there's equipoise here. I really don't want to give this patient a lot of protein. So, but we're also very big on pushing protein. So,
yeah, we'll come back to that topic in a minute,
okay.
Jen. Thanks.
Okay.
What about our legacy Salmon Creek colleagues? Anything? Could you please share your lived experience with screening and enrollment?
At our site, the screening process only happens Monday through Friday. We round with all disciplines in the morning, and that's the time when we look at new patients to see if they're appropriate. And Raquel, our ICU dietitian who's here too, is the one to generally ask the question to the intensivist as to how long the likelihood of they will continue to be vented. And that's really the first step before you look into other screening criteria. But Raquel could probably speak to those details a little bit more than I could.
Okay, thanks, Jerry. Raquel?
Like Jerry said, we usually go to rounds. This is our first clinical research anyways, and I want to take Ms. Charlene on the line right now. She helped me with the IRB application, so we're able to go up and running after 6 months of application. And so we do every round, so we ask our intensivist of the probability that the patient will be intubated for greater than 48 hours. And that's the conversation we're having with our intensivist. And from there, we enrolled our patients. I know we kind of have a lot of excluded patients, because right now we have almost more than half of what we enrolled as excluded. And partly some of that is there's a nephrologist that will not want, I think there's one or two that requested not to be enrolled. And most of it is because of the dietitian's clinical judgment of they're not comfortable of signing up the patients for the effort trial.
Okay.
And that's what I was talking about. Like, we have such a large population of patients in renal failure, liver failure, like that I wanted to include them, but you may get that pushback from nephrologists.
Yeah, we had one or two of that, and some of them, some of ours is like more of the BMI of the BMI, which is Dr. Highland already spoke to us about it. So BMI of, because in the inclusion it's like BMI greater or equal to 35, but one of the exclusion also is BMI of greater than 30, and also when we're using the hypocaloric feed of 11 to 14, then if you remind, so it's just comfortability of the dietitian if worried that if it got randomized to less than 1.2 and hypocaloric feeding of 11 to 14. So, but that conversation is already happened with Dr. Helen with us. So.
Yeah, maybe we'll jump ahead then to this slide since both of you are talking about it. What we're trying to do is increase the efficiency of the trial so that you have to screen fewer patients, and of potentially eligible patients, more get randomized than excluded. What we noticed so far in the trial is the main reason for excluding patients is that you as a clinician or you as a team lack equipoise, and you're saying that no, these patients either require a high dose or require a low dose. So that's the main reason people are getting excluded. If I explicate those patients that you say need a high or a low dose, so you're not comfortable randomizing them, that's what I'm showing you here are the reasons you're giving, not you personally, but you as a community who have screened and screened out some of these patients, you know, it's worsening renal function, worsening liver function, starting on dialysis, BMI greater than 30. Sorry, the rest of these aren't reading very well because of the projection, but there's these sundry reasons where you say, oh, no, I can't enroll this patient because, you know, they absolutely need, you know, high dose protein, or they absolutely need low dose protein. And following Jen's comments earlier, you know, optimally, we want as many of these patients enrolled in the trial as possible, so that these results are applicable broadly to all the patients that you're managing. We've tried to publish both a nibble and recently an NCP. It was just put online this past week, papers about the condition of equipoise, that in all of these conditions, even the ones on this slide, we really don't know what truth is. You know, whether high dose protein is required or low dose protein is optimal in whatever condition we're talking about. So for example, Raquel was talking about patients with high BMI. You know, there's these guidelines that our societies have endorsed that say high BMI patients require high protein and low calories. And so people feel uncomfortable, you know, randomizing a high BMI patient to either a high or a low being 1.2 grams per kilogram per day, which is still, you know, usual care. And I would push back and say, you know, those guidelines were written based on 2 randomized controlled trials of 46 total patients, mostly hospitalized patients, 13 of which were ICU, where the primary endpoint was nitrogen balance. And so when you consider the totality of the evidence saying that protein may be harmful, including the mechanistic work that protein may impair autophagy or impair mitochondrial function or cause muscle atrophy, and you've got larger observational studies or post hoc analyses of RCT showing that, you know, protein may be harmful, I would argue that even in our obese patients, our obese guidelines are not strongly grounded in the clinical evidence that we require to inform our practices. And it would be better for our community if we enrolled patients with obesity or patients with renal failure, et cetera. All of these subgroups need to come into the trial. Now, I recognize that I might be creating an uncomfortability because of what your practice patterns have been, but I would encourage you to review our written materials, either the nibble, which is a 4-page, very concise, here's the pros and cons, or the paper that was recently published in NCP, which is very similar, and discuss it with your clinical colleagues, because the truth is we don't know what the right answer is, and it would be way more efficient for you to be enrolling these patients in the trial than excluding them. And of course, as Jen said earlier, our results will be more maximally generalizable if we're able to enroll these patients rather than exclude them. So let me stop there and just see what comments, questions, or reactions you have to what's being discussed, please.
I agree, Jen.
I knew you were a supporter, Jen. What about others? What pushback might you have to this idea of why these people can't be enrolled in the trial?
I'm questioning about the wounds.
Okay.
The new, is there any study out there? Because I think that will be probably, you know, I understand the nephrology sometimes, but with the BMI, but how about the wounds that we know that high protein for wound healing?
Again, there's no RCT that demonstrates that higher protein is required for wound healing. There's lots of preclinical and observational studies to suggest that a higher protein dose may be helpful. And that's what has led to current practice patterns. But the same argument goes with if protein is harmful, which is what some people in our community are saying, then we need a higher level of evidence than anecdotal level of evidence that higher protein is harmful. And so we've actually, as you know, in the case report form, tried to codify people as having wounds at baseline. So that can be one of the subgroup analyses that we do based on whether someone has wounds, yes or no. We can look at the effect of the high versus usual level of protein. So again, my argument would be to continue to enroll those into the trial. In the end, if there's an extraordinary patient, and I'll give you an example of someone, say, with severe burns, with intestinal injury, where they had to, because of their burn trauma, they had to leave their abdomen open. They got, a high output fistula with lots of, oozing wounds, and they're going into renal failure on renal replacement therapy. So I use an extreme example of someone with huge protein losses, huge catabolism, where, okay, maybe you won't be that comfortable, randomizing them, but each of those individual aspects, someone in renal failure, period, someone who has burns, period, someone with a wound, period, someone with a high output period. I would think that there should be a level of uncertainty as to whether, providing high protein versus usual care is necessary. So those people could be randomized. Questions on that point?
Actually, I think that's a really good way to frame it, and I appreciate that. I would say also, as participating in this trial, it's definitely stepped up everyone's game in making sure the patients get the nutrition that they're prescribed. And I was thinking of another way to explain it to others, is to say, well, because we're doing such a much better job at providing exactly what the patient has been ordered to have, they're actually now getting more than any of the patients used to get, even when they were on a higher dose of protein. So that's probably the way I would argue it too.
Yeah, just to stress that point, Jerry, that people in the trial, in the usual care group, get 30% more protein than people in the INS data. To say that differently, in INS, we observe people getting 0.6 grams per kilogram per day. In the usual care group, in effort, they're getting 0.9.
Yeah.
Which is one of the reasons why people should get involved in research, because when people are being studied, performance improves. So your nutrition practice will improve by getting involved in research, because there's this improvement in the culture, improvement in the measurement, improvement in the monitoring, and it's one of the good byproducts of getting involved in effort. Other comments, questions on this topic?
I would second those comments. I think that being involved in INS 2 or 3 previous times, we definitely here at Penn, we're only providing in the 0.6 to 0.8 grams of protein per kilo range, even though we pride ourselves on being very pro-protein, but our actual delivery is much different than our prescription. So I think making that distinction between delivery versus prescription is a really important teaching point to get buy-in from different practitioners.
Thank you. Other comments?
Raquel has one.
I'm just wondering if we can minimize the exclusion criteria, because sometimes, if it's all written there, they will just highlight whatever fits in there. But should we just minimize that? And
so just Raquel, just to be clear, I'm just trying to go backwards, but I can only, there we go. These are the only exclusion criteria. The reason that we have this longer list on the next slide is because if you click lack of clinical equipoise as an exclusion criteria, we're asking you to tell us why. What is the clinical indication that led you to click that? If we didn't provide that taxonomy, you would write in something, and then across 150 sites and 4,000 patients, we would have to go through that written in text to codify it into these categories. So this list is not meant to be a list of exclusion criteria. This is the taxonomy of the clinical indications of why you said this patient doesn't have, why you don't have equipoise about this patient.
That's true. That's true. Thank you.
Yeah. Other people on the call, I'd love to hear from you with respect to this discussion we're having about how we get more of these patients that I'm showing you on the slide into the trial. Thoughts, reflections, comments, please?
Hello, Dan. It's Ricardo. I see that worsening of renal function has in a high amount here. But I discussed with the nephrologist in our ICU, and this is really not a problem. We tolerate higher amount of urea, blood urea, until 300, 310, it's okay. And any problem, we start the dialysis. So I don't understand really these three most important points here with high amount of people that have to abandon the study.
Yeah, and again, in those published papers that I referred to, both the Nibble and the NCP paper, we focus in on renal failure as a there's evidence that higher protein is helpful, and there's evidence that higher protein is harmful, or there's evidence that really is neutral, and we don't really know. And so it's in this population in particular that we wish we could get some higher RCT level of evidence that that higher versus what we're currently doing is better.
Yeah, in our last patient, the blood urea goes to 300, and the patient is still with good urinary output, and the dialysis just starts when the patient was overflowed, has an overfluid problem,
Yeah.
and not urea, in fact.
Yeah, and there is controversy, or rather uncertainty, about how high a urea can go, independent of the other criteria for initiating dialysis. And we face this with our glutamine work, where when we give glutamine, it stimulates ureagenesis. We see super high ureas, but there's no other clinical reason for dialysis, and so they just let it ride high and wait for other reasons for indications of dialysis, or the renal function gets better and they don't need dialysis. So yeah, making decisions based on urea alone seems not really necessary to just focus on the urea. Other thoughts and comments? So what I'm hopeful is that moving forward, to improve your screening efficiency, meaning the effort you put in to get a patient on study, and to increase the value of the trial itself, if we could get more of these patients in the trial, that would be great. And if you have individual questions, don't hesitate to reach out to me via email, to discuss that with me. I want to come back to something else that came up in the discussion with the UPenn group, when they talked about how when they got started, they were the first site that was started. They were, thinking of the INS days, and they were wanting to grab as many patients as possible. What we've recognized across the study is that, and what we're encouraging now, is we need to slow that down just a little bit, particularly at the beginning, to be sure that you're able to manage the workload of not only screening, but randomizing, and then monitoring that patient regularly, daily, if possible, to ensure that they're getting good separation of groups, or said differently, that to make sure that they're getting the right protein that they've been prescribed. And so we've evolved this idea that screening should be have an on and off switch. So that when you are screening looking for a patient, that's great. You do your screening logs, you keep track of everybody who meets the inclusion criteria, that gets recorded into REDCap. But once you find a patient whom you randomize, maybe you stop screening, and so you flip the switch off. You're no longer looking for consecutive patients, but rather you're focusing your energy on making sure that patient gets the amount of protein that they're supposed to get, collecting the data as necessary, and then when you and your team have enough resources to both manage patients on the existing trial and recruit new ones, then you flip the switch on and you begin screening again. Because I think what was happening, or what has happened in some sites, is they feel compelled to screen constantly and to enroll all eligible patients. And that has led them to randomize a lot, but not actually get that separation of groups, or not be timely in their data collection. And so just as a strategy to manage your time better, manage the workload better, please think about this on and off phenomena. So when you have time and resources, you're screening, you switches on, screen eligible consecutive patients, fill out the inclusion logs, the screening logs on all patients who meet the inclusion criteria. But feel free, when resources are limited, or when you've got enough patients on trial, to stop screening. And then at that point, you're not forwarding any forms on the screening log. So let me just pause and make sure everybody is understanding what I'm trying to say there with respect to how to better manage their workloads. Or any other participant on the call, feel free, if you want to clarify exactly how you make that work, or any other suggestions on improving efficiency, please. Thoughts, comments, or questions?
Randomness.
I am the perfect example of that. I think we're just planning to, and this is our first in our hospital, and we're planning to randomize one patient at a time. And we got an intensivist that is back, has a history of research, and wants to randomize everyone. And that just led me to in the beginning of the study.
Yeah. Well, we appreciate your enthusiasm. By no means do we want to diminish your enthusiasm. It's more of just trying to, slow down and measure your effort, so that you can do high quality work and not burn out, because you've got all these other clinical responsibilities as well. So yeah, it's been a learning experience for sure.
Yes.
Other thoughts or comments? Okay, well, the next agenda item was really just to focus on the other main concern in the trial, is the lack of separation between the two groups. I'm showing you a slide from one of our other key partners in Guadalajara, where they've been very successful in achieving separation. You can see the blue representing usual care and the red representing high dose. And so the yellow dotted line is actually the separation between the two groups. So we know it is possible, it is feasible, but overall, when we look at all the data in the trial so far, we don't see that much of a separation. There's only about 0.5 grams per kilogram per day, or maybe closer to 0.6, but it would be better if it was larger than that. To address this topic, we already had a webinar on strategies to improve the separation, on strategies to improve enteral nutrition delivery. We talked about increasing protein supplements enterally. We talked about the appropriate use of supplemental parenteral nutrition. So it is not my intent to go over that space again. It's more of just a reminder today that part of that time that you need to participate in this trial is time to make sure that you're getting that adequate separation between the two groups. And so that's why we're talking about that on and off switch with screening, and maybe slowing down randomization just a little, to be sure that you're making sure that the patients get the difference between or get at least 80% of what group they're assigned to. So if you haven't seen that webinar, it is publicly available, posted on our website. This is the sort of promotion of it. It's on YouTube. I think there's a link on our website, and also, what is this thing on the left here, Alfonso? Is that?
That's the thing in the left is the YouTube channel, and in the right is
Okay, but is it on our criticalcarenutrition.com website as well? Can they get a link there?
Yes.
Yes. Okay, great. So that's all I was going to say about this topic. Was there any questions on creating a greater separation between the two groups, or any tips or tricks that you've experienced that has been super helpful to you that you'd like to share at this point? Anyone?
I would say here at Penn, one thing that we could do better as we begin enrolling again is to, even if we're not sure if we're going to enroll patients, make sure that we're getting them up and started more quickly, because many times the patients would sit for a couple of days as we were thinking and considering about whether or not they met inclusion criteria. By the time you've met 2 or 3 days and realized that they're an appropriate candidate, you've accumulated a bit of a calorie and protein deficit. And then you're 3 days behind in getting things rolling. Clearly, that should be universal care for everyone, and all patients in the ICU should start nutrition very soon. But as soon as you start to identify that a patient could be enrolled, whether they're going to go into the trial or not, you should emphasize really getting an early initiation so that you don't have to catch up so much once you do randomize them.
Great comment. Thank you. And of course, that's why with our PEP-UP protocol, we bundled the initiation of enteral protein supplements with the initiation of enteral nutrition, so that early on we minimize that protein and protein calorie debt. Any other questions or comments? Well, at this point, what I wanted to say more is of an announcement, if not an incentive. You mostly are all familiar with the idea of a benchmark report, particularly if you participated in INS. We're getting to the point now where we have 5 or 6 sites that are near 30 patients, and so we're looking to produce our first round of sort of benchmark reports, which will not only help us identify what's going on in the effort trial, but like the prior benchmark reports, will give you other quality information on how nutrition is applied in your ICU. So this is more of an FYI and perhaps a bit of a motivation for those of you who are involved in enrolling, that if you can get to 30 or near 30 through the summer, then we'll produce a benchmark report this fall, which again should be helpful to you as participants in identifying what the opportunities for quality improvement are, or at least locally celebrating your successes and the things that you're doing well. Any questions or comments on the benchmark site reports?
This is Charlene. The benchmark site reports that our site got for INS participation were really helpful in terms of recognizing the performance. We didn't know how little protein we were providing. We thought that they were getting what we prescribed. And so I think those are really valuable in terms of your overall program, the quality of what you do. And data talk. It's easier to get support from the whole ICU team when you have data to show them of performance from their unit. So I think this is a really valuable incentive.
Thank you for that comment, Charlene. Indeed, this is one of the ways we're trying to give back to you as volunteer participants, is a tool to enable you to engage your clinical colleagues on defining and improving what your current practice is. Great. Other comments or questions? I just wanted to stress also that aside from that benchmark report, which will come out later this fall, I wanted to both remind you and ask a question about, we created this tool in REDCap, which was to enable you daily to monitor nutritional adequacy, right? Because if you've entered in the nutritional prescription, then, and you enter in daily how much intake they're getting, then you get this readout daily of that percent adequacy and also in absolute terms. Is this something that people are using? Is this something that people find helpful? Are you dependent on it? Do you have suggestions for improvement? So that's a mouthful of questions, but feel free to answer or respond to any of those, please.
This is Jen Dolan from Penn.
Yep.
We definitely use this. And we, in the beginning, had nurses doing the data collection for us once the patient was enrolled. And they would call us or email us at the end of the day with the patients that were actively in the study and say, oh, this patient only got X% of their goal. Make sure you talk to the team. Like we had a good structure there for that. So it's definitely helpful in catching it early rather than waiting till the end of the enrollment period and realizing that you didn't meet the distribution between the two groups.
Great, thanks for that endorsement. Many of the data you collect for this trial, such as duration of mechanical ventilation, for example, can be done retrospectively. But however, this is one of those data bits that we're strongly encouraging you to keep track of prospectively for reasons just illustrated. You can catch those deficits and respond quickly. Any other comments or questions?
This is Raquel from Legacy Salmon Creek. Currently, we're not doing it online. We have an intake form that we carry in rounds, and in rounds every day we document how much they take, and we calculate it and ask, having that conversation with the bedside nurse during the multidisciplinary team. But we don't have the ability to access it. But me and Ashley is talking about it. Probably we should try accessing it on during rounds. But right now we have a paper form.
Well, and Raquel, thank you for that comment, because I want to say that if you've got a paper form or another electronic tool that you're using to daily monitor and report on the adequacy, no problem. Then you don't have to use this tool. Maybe it's a bit cumbersome to access REDCap on your ward rounds. I guess the key point is that daily monitoring. And we would like to articulate that is best practices for nutritionally high-risk patients, that they be observed or monitored daily to see that they're reaching their targets. And so we just created this tool to help you. But if you've got something else, that's okay, as long as daily you're checking. Okay?
Yes, thank you.
Yeah. Any other comments or questions on this topic? I think one of the other sources of work, if not frustration, is managing the data queries and the user REDCap. So we just wanted to say a few words about that in terms of what might be proactively helpful for you to pay attention to. Jen or Alfonso, who am I turning the switch to?
It'll be me, Darren.
Okay, go ahead, Jen.
Thanks, everybody. Just a few things we want to set of reminders to help make your life easier. Your screening data that we require you to enter monthly in. This is usually, we like this completed. We don't care if you don't do it daily, but as long as by month end, you have it in, because we run our reports at the beginning of the next month. And so then if you haven't had the chance to do your data entry, it just reflects that your site looks like it hasn't done anything at all. So, I mean, I understand that your patients that you're going to enroll will be screened, but any other additions of screening should be entered in at least monthly at a minimum to help you ease some of that burden of workload. The other thing I want to remind people is to Ensure that when you start your screening data, for those patients that meet all eligibility, that should be screen failures, or for some reason, if you're a consenting site, they don't agree to participate, and you've got to complete the reasons. Sometimes it alters the reporting results when you leave the screening data incomplete. So please try to ensure that if you've started somebody in the inclusion phase, and let's say they fell out at exclusion, so they met a few of the criteria, make sure you complete the form and complete the data. So I just wanted to remind people of that. I'll be putting it in the newsletter, in the upcoming newsletter, just to remind people as well. And some of you might be getting more emails from us directly just to capture on this point. Let's talk about data collection reminders. We usually try now with sites as soon as they come on board to give them a few tips rather than sort of get caught and start doing loads of data entry and realize, oh, I thought day one was randomization date. So just want to make sure that you're using the current resources from the site. We are updating them constantly with new things, and usually we'll let you know in the newsletter if things have changed. Another point to remember is your flow sheets might not adhere to how the data collection tool works for REDCap. So we collect data from midnight to midnight. So if you're a site that has flow sheets that don't run like that, it's going to be a little labor intensive to collect your data, but it has to be reflected in that 24-hour time frame. Does anybody have troubles with this at their sites?
This is Jen from HUP. We're fine with that. Our flow sheets are midnight to midnight.
Perfect. Anybody out there who's collecting data that doesn't have a flow sheet that's not midnight to midnight and finding things complicated, or is everybody all right with data entry?
It's Raquel from Legacy. We don't have midnight to midnight except the intake tab, but the rest are 7 to 7. Got it.
And are you okay with your data for your flow, doing your data entry? You're working it out because your intakes are on the 24-hour clock then?
Yes, our intake is 24-hour clock, but the rest are like 7 to 7.
Okay. Andrea, I see you have a comment. I don't know if you have a mic, but I see you've chatted and said that it's very time consuming and hard to be accurate.
Yeah, what we find, can you hear me?
Yes.
Oh, okay. So what we find is that often in our ICU, while they're good with doing intakes, they sometimes just, when they're on a tube feed, and they're fairly stable, they'll just put the ground total in at the end of the shift, the 7 to 7 or whatever overnight. But sometimes you'll see in the nurse's notes, if it's not 100% of their feeds, it might be an interruption, but there might not be times. You might not know exactly how that all rolled, whether it happened before midnight or after midnight. Sometimes the nurses don't even chart an interruption or whatever. So it does become difficult because once you come in and check with the day nurse and you say what happened overnight, they say, I have no clue. They didn't say anything to me in handover. So it takes a lot of extra time to try and prep the bedside nurses to be, really diligent with what's happening with their feeds.
You thought about making a one-time, I don't know if we have one already made, but a 24-hour, just in a sheet to collect your enteral data that they can, enter it hourly for you on the form. So at least there you've got, you can figure out your 24-hour time frame and just add up, do the math and add it up. Would that be less of a burden? Would you think your nurses would be apt to recording the data for you that way?
Unlikely, but it's worth an ask. I mean, we're a teaching hospital with a lot of studies going on all the time and all sorts of things. So, this is it's tough to add one more thing to their plate, but I haven't quite figured out what the solution is, whether it's just asking them to, chart a little bit more effectively when they're writing, or whether they should have yet another piece of paper, because right now there's a whole lot of pieces of paper that go on for their recording of all sorts of other things. So.
This is Darren. Can I just make a few comments on this topic? I've been doing nutrition research for near 20 years, and so I'm familiar with the problem of the accuracy of the documentation. I want to remind those of you that have access to and know how to interrogate your pumps, because they are the gold standard of what the pump actually delivered. And so think about using that as a resource, not only for collecting your data, but also for that audit and feedback of what your nurses document. You may find discrepancies, and you can use that to try and correct their behaviors. One of the byproducts of getting involved in nutrition research, where you're collecting this nutrition data, is we see that these nursing documentation issues actually improve now that they know that somebody's auditing their charts or looking at their documentation. The natural experience is that they do a better job. So I would encourage you to verbalize feedback, not only to bedside nurses, but to nursing management, not in a pejorative way or a critical way, just in a matter-of-fact way. Hey, I'm supposed to be collecting these data and I see these discrepancies, or I see these gaps, or I see these absences of data. Is there a way we can work as a team to improve that? In the end, if you can't, if you don't have adequate documentation to figure out how much was delivered before midnight or after midnight, obviously we would respect your best guess. In another trial that we've done, and Jen, I'm going to put this on your Jen Coral. I'll just ask you to follow up with Maureen, because we do have a little bit of a worksheet just that either the dietitian or the bedside nurse is filling out, that goes from 24 to 24, so that if your nurses are willing to, because they recognize the deficiencies of what they're doing otherwise, for effort trial patients, which is what, 1 or 2 or 3 a month, could they just fill this out as in terms of what the hourly volumes were working from midnight to midnight? And so, Jen, perhaps you could get that from Maureen and circulate that for those sites that want to and can use it.
Perfect, will do. Thanks, Darren, for the suggestion. I see Linda is typing, and I don't think she has access to a mic, but she's saying her flow sheets are 7 to 7, and she just does the math. Now, Linda, I'm not sure if you can answer me as quickly as I can talk, but is it recorded hourly, or is it recorded for the 24 hours, just a N number for the whole shift period? Because then for many times that I've done source, I end up taking 2 flow sheets, opening them up, and then just taking the hourly over the 2 flow sheets to make the 24-hour period. So I'm not sure what you're saying in terms of your comment, but I'm asking you to clarify for me. And she's also saying that her nurses wouldn't do it on paper as well. Here's where you're...
I think that she's talking about taking the 2 flow sheets that are hourly and trying to just make that work midnight to midnight. That's exactly what our worksheet tries to do, just to help you not make mistakes in the calculation. Is there's a value that gets recorded, from midnight to the next midnight for every hour. Either the nurses do that instead of the flow sheet, or as you're extracting or abstracting across 2 flow sheets, you just record that and then sum it up, and it minimizes error.
Perfect. Thanks, Darren. So moving on to the next point, I'm just trying to outline a few data collection clarifications just to eliminate queries for you. I want to bring your attention that when you're collecting vasopressor data, for those that are receiving it, just pay attention to the units when you're entering it. It'll just save you queries and save you time. So we just wanted to highlight that fact, as well as the lab units. We recently encountered a little ambiguity between the BUN and the urea. And so we've just restructured the page to make it a bit more clearer. So for the sites that have entered no BUN and urea, we're sort of going back to clarifying, is it just because it was ambiguous and you weren't clear? And so that we're might approach your site if you are one of those. But moving forward now, it has been changed, so it'll ask you which one you're collecting. So if there's anybody that's had trouble with that, feel free to connect with me offline, and we can go over it. But a newsletter will be followed, letting you all know about the change. So hopefully it'll take away some of the misunderstanding. And I don't know how people are finding the queries. I just want to let people know for the sites that are new to the system and the query system, as you're starting data entry, don't get too hung up as you're seeing that number rack up on the left-hand side of the screen in red cap. If you're leaving forms incomplete, it's basically letting you know that there's a lot of blank fields. So don't waste your time worrying about them and answering them, because they're going to go away once the data has been saved and the form is completed. So I just want to bring your attention to do that, to take note of that. Usually we let people know that once your data is all completed, then that's a good time to sit down and spend a little bit of time to go through whatever queries that you have. You'll have the chart with you. Everything will be fresh about being able to answer them. And so that'll be, we find that's more suggestible to sites about how to tackle your queries. Is anybody hung up on the queries, or anybody having loads of difficulty with the queries? Okay. And then I guess finally, something new that well, not new now, but for sites that are coming on, we're right after you've enrolled 4 patients, and at least we have 2 in the high group, we're doing a touch-based call. So this is more to ensure that the adequacy is being delivered adequately to those patients in the high group. So we'll give you a little warning. We'll let you know that we're going to do this. We're looking for you to enter just your nutrition data for us to be able to develop the report. Then we'll connect with you with an agreeable time that we could quickly just learn about your experiences, learn about what's hard for you at your site, or what's easy, what you can share with us, that what changes, what can we learn from your experiences with the first 4 patients. So we've been quite successful. We've done numerous amounts of them, and then we discover those sites who are doing it right and those who are having troubles doing it. So this is a useful task that we've been doing with all our new sites that are coming on board. Does anybody have any feedback about the touch-based process if we've already done one at your site? Has it been something that's been helpful for you?
This is Jen Dolan. I think Mary Ann's done most of our communication with you, so.
Perfect. Yeah. Okay, great.
Yeah, and I think we enrolled prior to the evolution of the touch-based calls.
Yeah, that's correct, you did. Okay, so that's it for me. If there's any questions, I'm more than happy to take anything, or if you want to connect with me offline, feel free.
Okay, great. Thanks, Jen, and thanks for all your work in the background to help with the operationalization and quality of this trial. Appreciate work you and Alfonso are doing. Sorry?
Welcome.
Okay, great. Just before we close, and I'll also just pause it near the end before we close for any open questions that you might have. But by way of information, I just wanted to let you know of a couple of exciting sub-studies that are happening within the effort, the larger parent effort trial. I have a PhD student in University of Malaysia in Kuala Lumpur who is doing a project where they're combining the high dose group with cycling. Some of you may know my work with the Nexus protocol, where we're combining cycling and intravenous amino acids compared to usual care, looking at a 6-minute walk test as a primary outcome. In this trial, he's merging the Nexus idea and the effort idea together, and has a little sub-study called Effort X. The primary outcome for this trial will be ultrasound, but there's a whole series of those functional tests, hand grip strength, handheld dynamometry, etc., that we use in Nexus, that we'll be using in these 120 patients in Effort X. Similarly, we have another site in Australia that is doing what we call Effort. Effort Combo is not that. Effort Combo is combination of enteral and parenteral nutrition. So rather than let you elect when to use PN as a strategy to get the higher dose protein, this sub-study is empirically starting off with both enteral and parenteral in the high dose only. And the outcomes are going to be the same as what I just showed you on effort X, this whole battery of functional outcomes, except the primary outcome here is the 6-minute walk test, and we're aiming to get 142 patients. This trial is conducted in Germany and Switzerland, and there may be one other European country, so maybe the UK, yeah. And then this one is one that is still in early stages, where it is similar to the prior 2 trials, except it's really only nesting the outcome, the suite of outcome assessments into the parent effort trial. So the 6-minute walk test and a number of these other tests will be done so that we will have some functional outcomes to be able to evaluate, does the high dose actually make a difference, which is pretty cool. And then last but not least is an ultrasound sub-study where everything stays the same with respect to the parent effort trial, but we embed into that trial an ultrasound measure at baseline, day 10, and hospital discharge. So again, we'll have ultrasonography measurement of muscle mass as an outcome that we can talk about in terms of the impact of protein. I tell you these things by way of information, but if anybody's interested in participating in effort ultrasound or effort outcomes, those are kind of open studies. They are not funded, but we would be willing to train you on how to do these assessments, how to do ultrasound. In fact, you can see our website for more details on a conference this fall in Panama in October, where we're training effort investigators on how to do the ultrasound, with an expectation then that they'll layer that in to the patients that they enroll in the effort trial at baseline, day 10, and prior to hospital discharge. So if you're interested reach out to me offline. There's more information on effort ultrasound on the website. Are there any other, are there questions about those sub-studies? And then I'll open it up to general questions. Questions on the sub-studies?
Nope.
I have a question. With the sub-study, would you have to collect all those outcome measures, or could you, like, for example, just do the hand grip, or would you need to follow the protocol exactly?
Yeah, it's a good question. I think for the effort outcomes, which is where we want that battery done, we would want all done. If what you're proposing is we just do hand grip strength, because I know that's a common tool for many dietitians or nutritionists to use, we could think about, just enabling you to enter in that information if it's available, if people are willing to do it. But that would be sort of an addition to the parent effort trial. Let me say that differently. The effort outcomes protocol, as I suggested, is going to be the complete battery. So if you're just doing hand grip strength, we'd have to think about a separate protocol and data collection strategy to collect that data. I'm not sure it'd be worth it in those sites that don't have to collect consent, because you probably have to consent somebody to get that hand grip strength, at day, well, I guess just at hospital discharge, really. I'll have to think some more about that, but we can talk offline if you're interested in pursuing that further, Mary.
Okay, yeah, that'd be so easy for us to add.
Yeah, okay. Well, let me think about it some more.
Darren, if hand grip strength is part of usual practice in an institution, I don't think that they'll have to get consent for that.
Oh, you're right. You're right. And that makes it even easier to implement. So what we'd have to do, though, at least is try and standardize when we were doing it, and then we'd have to open up a field in REDCap so that you could enter that information.
Dr. Highland, this is Raquel from Salmon Creek, and we're also interested with the hand grip strength because it's part of our usual care.
Okay, great. Any other comments on that topic? or any of the other sub-studies? Okay. Any other questions? Open questions or comments about the effort trial? Okay. Well, if not, we'll close. Let me thank you again for not only your involvement in the trial, but your willingness to join the call today and share your experiences. Our goal was to just trying to create a bit of a dialogue with sites actively involved in the trial, share best practices, learn where the study's at, and make some adjustments so that we can improve quality and performance. I hope you realize that both speaking on behalf of Jennifer and myself and Alfonso, we're very open to questions, to engagement, to ideas. So please don't reach out to hesitate to us after the fact if you've got some things you want to discuss with us. So good luck in screening, good luck in finding more patients, and spread the word out. If you've got other colleagues in your regions that are interested in effort, we could still use a few more sites to join this year. Thanks, everyone. Enjoy the rest of your day.
Thank you, Darren.
Thank you.
Bye.
Bye-bye.